Good morning. Hope you're doing well today. Today we are we're continuing our conversation in chapter 22. This is over cerebral palsy. So here we go. Cerebral palsy is a group of neurological disorders that affect movement, posture, and muscle coordination. The classification of cerebral palsy is based on different factors, including the type of movement disorder, the parts of the body affected, and the severity of the condition. The classification of cerebral palsy, or CP, includes several components related to motor abnormalities. These components help describe the specific motor impairments and characteristics of an individual with CP. The motor abnormalities component commonly included in the classification of CP are as follows. The type of motor impairment. Spastic CP is characterized by increased muscle tone and stiffness, leading to difficulties with movement control. Dyskinetic CP involves involuntary and uncontrolled movements, including dystonia, which is sustained or repetitive twisting or writhing movements, and athetosis, which is slow writhing movements. Ataxic CP is associated with problems in balance, coordination, and voluntary movements, resulting in shaky or unsteady movements. And mixed CP includes a combination of different types of motor impairments. The Gross Motor Function Classification System, or GMFCS, is commonly used to assess the severity of motor impairment in CP. It categorizes individuals into 5 levels based on their functional abilities, mobility, and need for assistive devices. Alongside the primary motor impairments, individuals with CP may have additional motor abnormalities or associated features. These can include oral motor dysfunction, which affects speech and swallowing, fine motor difficulties, gait abnormalities, muscle weaknesses or imbalances, and contractures, which is muscle tightness or stiffness. It's important to note that the classification of CP is not limited to motor abnormalities alone. Other factors such as intellectual functioning, communication abilities, and associated impairments may also be considered in a comprehensive classification system for CP. The classification is useful for healthcare professionals in understanding the specific motor impairments and needs of individuals with CP and guiding appropriate interventions and support. Anatomical and neuroimaging findings can provide insights into the underlying structural and functional changes in the brain associated with the CP. It's important to note that the specific anatomical and neurological findings can vary widely among individuals with CP depending on the type, severity, and cause of the condition. These findings provide valuable information for understanding the underlying brain changes associated with CP and can help guide diagnosis, treatment planning, and interventions for individuals with CP. The distribution of motor impairment with cerebral palsy is based upon the classification describing the distribution of motor impairment based on the parts of the body affected. One particular is hemiplegia, which one side of the body is affected, typically including an arm and leg on the same side. Diplegia primarily affects the lower body, with the legs more involved than the arms. Quadriplegia is where all 4 limbs, as well as the trunk and head, are affected. And monoplegia, which is only 1 limb that is affected. The severity. With the classification system, it's used to describe the functional impact of cerebral palsy. The Gross Motor Function Classification System, or GMFCS, is commonly used for that purpose, as we talked about earlier. Cerebral palsy can be accompanied by various associated features such as intellectual disability, speech and language impairments, visual or hearing impairments, epilepsy, and musculoskeletal abnormalities. The classification may take into account these associated features to provide a comprehensive description of the individual's condition. While not always included in the classification, the underlying cause or etiology of cerebral palsy can also be considered. Causes of CP can include prenatal factors, perinatal factors, and postnatal factors such as genetic abnormalities, maternal infections, birth complications, or traumatic brain injuries. It's important to note that different classification systems may have variations in the components used to describe cerebral palsy. The classification is typically determined through a comprehensive assessment by the healthcare professional that includes medical history, clinical examinations, and imaging studies and developmental evaluations. This helps in understanding the unique characteristics and needs of individuals with cerebral palsy and guides the development of appropriate interventions and support. Spasticity is a common motor impairment associated with cerebral palsy. It is characterized by increased muscle tone, stiffness, and resistance to movement. Here are some key points about spasticity in CP. Spasticity refers to the involuntary contraction and tightness of muscles, leading to difficulties with movement control and coordination. Spasticity in CP results from an imbalance of signals between the brain and the muscles. Damage or abnormalities in the motor areas of the brain, particularly the motor cortex and corticospinal tracts, disrupt the normal regulation of muscle tone. There are different types of spasticity. Flexor spasticity is an increased muscle tone and tightness, primarily affecting the flexor muscles, resulting in a characteristic pulling or curling posture. There's extensor spasticity, which is an increased muscle tone or tightness predominantly affecting the extensor muscles, causing stiffness and difficulty in maintaining a straight, upright posture. There are clinical features associated with CP. Hypertonia is the affected muscles have increased resistance to passive stretching. And clonus is a rapid involuntary muscle contraction, often triggered by a quick stretch of the muscle. Hyperreflexia is an exaggerated reflex response when the corresponding tendon is tapped. And spasms, involuntary and sometimes painful muscle contractions, often occurring in response to certain triggers or stimuli. The impact on function is based upon the spasticity can have a significant impact motor function, leading to difficulties with movement, coordination, balance, and posture. It can interfere with activities of daily living, mobility, and participation in functional tasks. As far as treatment and management, the management of spasticity in CP involves a multidisciplinary approach, including physical therapy, occupational therapy, medications, orthotics, and sometimes surgical interventions. Physical and occupational therapy aim to improve range of motion, flexibility, strength, and functional abilities. And medications such as muscle relaxants or botulinum toxin injections or Botox may be used to reduce muscle tone and spasticity. Orthotics such as braces or splints can assist with maintaining proper alignment and improving functional mobility. It's important to note that while spasticity is a common feature of CP, not all individuals with CP experience spasticity, and the severity can vary. Each person with CP may have a unique combination of motor impairments, and treatment approaches should be tailored to their specific needs and functional goals. Dystonia is another motor impairment that can be associated with CP. It is characterized by involuntary muscle contractions that cause twisting or repetitive movements and abnormal postures. Here are some key points about dystonia in CP. Dystonia refers to sustained or intermittent muscle contractions that result in abnormal postures or repetitive movements. These contractions are often involuntary and can be painful. Types of dystonia in CP, there's focal dystonia, which affects only one specific body region, such as the hand, foot, or neck. Segmental dystonia affects two or more adjacent body regions, such as the arm and hand or the leg and foot. And generalized dystonia affects multiple body regions, often involving both the upper and lower limbs and the trunk. As far as clinical features, there are involuntary movements such as twisting, writhing, or repetitive movements that may be slow or rapid. Abnormal postures with unusual positioning of body parts such as sustained flexion, extension, or twisting. And task-specific dystonia, which may be triggered or worsened by specific activities or tasks. Dystonia can significantly impact functional abilities, including activities of daily living, mobility, fine motor skills, and speech. It may lead to difficulties with grasping objects, walking, riding, and maintaining proper posture. The management of dystonia in CP often involves a multidisciplinary approach, including physical therapy, occupational therapy, medications, and sometimes surgical interventions. PT and OT, as we mentioned, help to improve range of motion, strength, and functional abilities while addressing specific dystonic postures and movements. Medications such as muscle relaxants, anticholinergic drugs, and Botox injections may be used to reduce dystonic muscle contractions and improve motor control. Deep brain stimulation is a surgical treatment option for severe and refractory cases of dystonia in CP. It's important to note that dystonia can present in varying degrees of severity and affect different body regions in individuals with CP. The treatment approach should be individualized based on the specific needs and functional goals of each person. A comprehensive evaluation by a healthcare professional experienced in managing dystonia in CP is essential to develop an appropriate treatment plan. So as we've talked about, cerebral palsy is a group of neurological disorders that affect movement, muscle tone, and coordination. It is caused by damage or abnormalities in the developing brain, usually before or during birth, but can also occur in early childhood. Motor impairment refers to difficulties or abnormalities in movement control and coordination. In the context of CP specifically, it relates to the challenges individuals with CP experience in controlling their muscles and executing voluntary movements. Spasticity is a form of increased muscle tone characterized by involuntary muscle contractions and stiffness. It leads to difficulty in relaxing muscles and can affect mobility and movement patterns. Dyskinesia refers to involuntary and abnormal movements, including repetitive, twisting, or writhing motions. It can manifest as dystonia, which, as we talked about, as a sustained muscle contraction causing twisting or abnormal postures, or athetosis, which is slow, involuntary, and writhing movements. Ataxia is a lack of muscle coordination, resulting in unsteady movements and difficulty with balance and posture. It can affect fine motor skills, speech, and overall coordination. Hypertonia refers to increased muscle tone or stiffness, making movement and stretching of muscles more difficult. It can be a characteristic feature of spasticity. Hypotonia is a state of reduced muscle tone, leading to floppiness or low muscle tension. It can result in decreased muscle strength and difficulties with posture and movement control. The GMFS-CS is a standardized system used to classify the gross motor function of individuals with CP. It categorizes individuals into 5 levels based on their functional abilities and mobility, providing a framework for assessing motor impairments and planning interventions. Functional mobility refers to an individual's ability to move and navigate in their environment to perform daily activities. It encompasses activities such as sitting, standing, walking, transferring, and using assistive devices for mobility. Assistive devices are tools or equipment that assist individuals with CP in enhancing their mobility, independence, and participation. Examples include wheelchairs, walkers, crutches, orthotics, and adaptive aids for activities of daily living. These definitions provide a basic understanding of some key terms related to cerebral palsy. It's important to note that the experiences and specific impairments can vary among individuals with CP, and a comprehensive assessment by a healthcare professional is crucial for accurate diagnosis, treatment planning, and intervention strategies tailored to that person's unique. The gross motor function classification system, as we talked about, is a widely used classification system that categorizes the gross motor function of individuals with CP. It helps assess and describe the functional abilities and limitations related to mobility in individuals with CP. There are 5 levels, each representing a different level of mobility. Level 1, individuals at this level can walk without limitations. They may have slight abnormalities in coordination, speed, or balance, but Their mobility is generally unrestricted. They can perform most activities of daily living independently. Individuals in level 2 can walk independently on level surfaces, but may require assistive mobility devices such as walkers or crutches for longer distances or in crowded environments. They may experience difficulties with uneven terrain or long periods of walking. With level 3, individuals typically require assistive devices such as walkers or wheelchairs for mobility. They may walk short distances with assistance or use powered mobility devices for greater independence. They may have limitations in outdoor mobility or in uneven surfaces. With level 4, individuals at this level primarily use powered mobility devices such as wheelchairs for mobility. They may have limited ability to walk with assistance, typically for short distances in specific environments. They may require significant support and adaptations for mobility and activities of daily living. And level 5, individuals at this level have severe limitations in mobility and typically rely on assistive technology such as powered wheelchairs for mobility. They may have limited voluntary control over movement and may require extensive assistance for activities of daily living. It's important to note that the GMFCS classification focuses on gross motor function and mobility. It does not provide a comprehensive assessment of other areas of functioning, such as fine motor skills, communication, or cognitive abilities. The GMFCS levels serve as a general guideline and aid in communication and among healthcare professionals, researchers, and families, helping to guide treatment and planning and interventions for individuals with CP. When conducting exercise tests for individuals with CP, it is important to consider their unique abilities, limitations, and specific needs. Here are a few exercise tests commonly used for assessing fitness and functional abilities in people with CP. The 6-minute walk test measures the distance an individual can walk in 6 minutes. It provides an indication of functional endurance and walking ability. Timed up and go or tug test assesses mobility and dynamic balance and measures the time taken for an individual to stand up from a chair, walk 3 meters, turn around, walk back, and sit down. The 10-meter walk test measures the time it takes for an individual to walk a distance of 10 meters at their comfortable walking pace. It assesses walking speed and ability. The step test involves stepping up and down a platform or step for a specific duration, usually 1 or 2 minutes. It assesses lower limb strength, endurance, and cardiovascular fitness. Muscle strength testing can be conducted to assess the strength of specific muscle groups. This can be done using a dynamometer or through functional strength testing, such as measuring the ability to perform specific movements or tasks. For individuals with higher functioning abilities, a modified version of the Bruce protocol, a standardized treadmill test, can be used to assess cardiovascular fitness and endurance. It is important to adapt a modified test as needed based on the individual's functional abilities and any accompanying physical or cognitive impairments, working, of course, with their healthcare professional and with this physical therapist can help with developing their exercise program based upon and determining what is an appropriate test selection for safety during the testing process. You'll note that what we've talked about in the table 2210, there are other tests that you can do as well. Just really important that, again, you select the correct or the right one for safety purposes. Exercise testing and training for clients with cerebral palsy should be individualized and tailored to their specific abilities, limitations, and goals. Here are some considerations for exercise testing and training in individuals with CP. Before starting any exercise program, it's important to conduct a comprehensive assessment of the individual's physical capabilities, medical history, functional abilities, and any specific needs or limitations. This assessment may include evaluating muscle strength, range of motion, balance, coordination, cardiovascular fitness, and any associated impairments. Work with the individual and their healthcare team to establish realistic and meaningful goals for the exercise program. These goals may include improving strength, flexibility, cardiovascular fitness, mobility, balance, or specific functional tasks. Modify exercises and equipment as needed to accommodate the individual's abilities and limitations. This may include using assistive devices, adjusting exercise intensity or duration, and providing adequate rest periods. Incorporate resistance exercises to improve muscle strength and endurance. Focus on both upper and lower body exercises targeting specific muscle groups based on the individual's needs. Use a variety of exercises such as body weight exercises, resistance bands, or weight machines depending on the individual's capabilities. And include stretching and range of motion exercises to maintain or improve joint flexibility. Pay particular attention to areas of tightness or contractures commonly seen in individuals with CP. Incorporate exercises that challenge balance and coordination, such as standing on one leg, balancing on unstable surfaces, or performing dynamic movements that require coordination. Include aerobic exercises to improve cardiovascular fitness. This can be done through activities such as walking, cycling, swimming, or using adapted cardio equipment based on the individual's abilities and preferences. Incorporate exercises that mimic or directly target functional movements and activities that are important to the individual's daily life and functional goals. This may include tasks such as sitting to standing, transferring, or practicing specific motor skills. Regularly monitor the individual's progress, adjust the exercise program as needed, and gradually progress the intensity, duration, or complexity of exercises to continue challenging their abilities. Ensure proper supervision, use appropriate equipment and modifications, and be aware of any medical conditions or precautions that may affect the individual's ability to engage in certain exercises. It's important to work with healthcare professionals, again, in designing and implementing their exercise program that meets the specific needs and goals of each individual. Regular communication with the healthcare team can help monitor progress and make necessary adjustments to the program over time. As we've talked about, when prescribing exercise for individuals with CP, it's essential to consider their unique abilities, their functional limitations, and individual goals. Each individual with CP is unique, and exercise programs should be tailored to their specific needs, abilities, and limitations. You should consider their age, level of motor impairment, associated impairments, and functional goals. You want to include exercises that target multiple dimensions of fitness, including strength, flexibility, cardiovascular endurance, balance, and coordination. A well-rounded program can help improve overall functional abilities and enhance their quality of life. Begin with a low-intensity exercises and gradually increase. This allows the individual to adapt and progress at a safe and manageable pace. Incorporate resistance exercises to improve muscle strength and endurance. Focus on both upper and lower body exercises targeting specific muscle groups based on the individual's needs. Use a variety of exercises such as body weight exercises, resistance bands, or weight machines depending on the individual's capabilities. And include stretching and range of motion exercises to maintain or improve joint flexibility. Pay particular attention to the areas of tightness and contractures commonly seen in individuals with CP. Gentle stretching exercises can help alleviate muscle tightness and improve their overall flexibility. You want to include aerobic exercise to improve cardiovascular fitness. Choose activities that they enjoy and can safely participate in, and modify the intensity and duration to match their abilities and gradually increase as tolerated. Incorporate exercises that directly target functional movements and activities important to the individual's day of life, such as transferring from different medias, walking, or using assistive devices to enhance functional independence. Modify exercise and equipment as needed to accommodate their abilities and limitations. And provide appropriate supervision, and again, collaborate with their healthcare professional. Research on the outcomes associated with exercise for individuals with CP has shown various positive effects on their physical and functional abilities. Regular exercise, including strength training and aerobic exercise, has been associated with improvements in motor function in individuals with CP. It can lead to increased muscle strength, improved coordination, enhanced balance, and better motor control. Exercise interventions such as gait training and functional mobility exercises have shown to improve walking abilities in individuals with CP. They also experience increased walking speed, improved endurance, and enhanced overall mobility. Exercise programs targeting gross motor skills have been found to positively impact the development and acquisition of fundamental motor skills in children with CP. These skills include crawling, walking, running, jumping, and overall motor coordination. Regular exercise, including stretching and range of motion exercises, have been shown to reduce muscle spasticity in individuals with CP. This can lead to increased flexibility and improved range of motion and decreased muscle stiffness. Aerobic exercise programs have been associated with improvements in cardiovascular fitness, endurance, and overall cardiovascular health in individuals with CP. And that can contribute to better overall health and increased functional capacity. Engaging in regular exercise has been linked to positive psychological and social outcomes in individuals with CP. It can boost self-esteem, improve mood, enhance social interaction and inclusion, and provide opportunities for participation in recreational activities. Exercise programs that focus on functional training and activities of daily living have been shown to enhance functional independence and improve quality of life in individuals with CP. They can increase self-care abilities, facilitate independent living, and enhance overall well-being. It's important to note the outcomes of exercise interventions may vary depending on individual factors such as the severity of CP, associated impairments, and adherence to the exercise program. And you do, again, want to consult with their healthcare professionals who can help you in designing and supervising individualized exercise programs based on their specific needs and abilities of each person with CP. And this concludes our journey in Chapter 2, where we are talking about spinal cord injury, multiple sclerosis, cerebral palsy, and epilepsy. Increasing and sustaining moderate to high levels of physical activity among persons with these diseases is strongly encouraged. Many people in these groups are at an increased risk for chronic metabolic disorders, partially because of the high frequency of physical inactivity among the populations. So personal trainers working under the guidance of healthcare professionals should make an effort to promote their services to populations with the disorders covered in this chapter. That is all that I have for you today. I look forward to talking with you again